السلام عليكم ورحمة الله وبركاته. يسعد أن أكون معكم مرة أخرى ضمن فعاليات طب الأسنان المباشر. أولا أريد أن أشكر دكتور مازن دوماني على جهوده الرائعة في إتمام هذا المؤتمر العلمي. إن شاء الله تكون محاضراتنا تعم بالفائدة على الجميع. Good evening everyone. My name is Ahmad Hawasli. I am a periodontist working in the United States in Virginia. Today I will talk about the radio augmentation or the GBR. During this presentation, I will explain the main protocol of the GBR, present some simple cases that we can learn from and can help us in our practice. First of all, I'm going to start with classification of the ridge deficiency according to the CBERT. As we know, we have the class 1 when we have only horizontal bone loss, and we have class 2 when we have a vertical bone loss, and we have class 3 as shown on this picture when we have combined vertical and horizontal bone loss. And as we know, there are different methods to do the GBR or the radio augmentation. We can do distraction osteogenesis, or we can use a bone block, we can use a ridge expansion, or GBR using a particulate graft, or even we can use soft tissue ridge augmentation. And of course, each method has its own indication. Today I will focus mainly on number 4 and number 5, the GBR using particulate graft and also the soft tissue ridge augmentation. And inshallah I will discuss about the other methods in the future. So the GBR with particulate graft is mainly indicated when we have content defect and when we need to do lateral augmentation, or even when we need to do moderate vertical augmentation. So does the GBR generated bone function as the pre-existing alveolar bone؟ يعني احنا العظم اللي يتشكل معنا بعد ما نعمل الجي بي ار هل هو كالعظم الأصلي النيتيف بون ولا في اختلافات؟ حسب دراسة لبوزر in 1995, bone regenerated in membrane protected defects respond to the implant placement like non-regenerated bone, and that this bone is capable of bearing and sustaining the functional load. Histologic comparison of the restored and unrestored sites demonstrated no apparent difference concerning the bone remodeling activities. We have also another study to Dallin in 1991. Newly formed bones seem to be able to bear the stress when loaded with a fixed dental prosthetic construction. مثل ما ملاحظين هون إنه العظم اللي بشكل معنا لا يختلف عن العظم الأصلي أو الأفير بون، فيمكن أن يقاوم أيضا الميكانيكال الفورسز بعد التعويض، بعد وضع الزرع وبعد التعويض. Fogazato, in his study in 1998, they did 289 ridge augmentation in buccolingual direction, and they used non-resorbable membrane in the cortex, and also they used an FDBA graft, and they found that in 279 buccolingual demonstrated sufficient regenerated hard tissue for implant placement, and this represents an overall success rate 97% for horizontally augmented ridge. So mainly in this study they talk about the horizontal ridge augmentation, and they use non-resorbable membrane with FDBA, and they showed the 97% of the success rate. Boozer in other study in 1990, the ridge augmentation was completed using PTFE membrane in GTR in 12 patients. In this study they used non-resorbable membrane, but there was no bone graft. They used only the membrane to cover the defect, and the gain of the new bone formation after 6 to 10 months healing period was 1.5 to 5.5 millimeter. فنحن بدنا ننتبه حسب هالارتكل، بدنا ننتبه نحن لما نعمل horizontal ridge augmentation we have to expect that we only can gain between 1.5 to 5.5 millimeter. We can get more usually. يعني نحن وعنا خلينا نقول 3 millimeter ridge width we can't get more than 7 to 8 millimeter average width. So we have limitation when we do GBR with the particles. So how many different barrier material and bone graft media have been used for the GBR? مثل ما بنعرف we have different sources for the bone graft. We can use either the allograft, or we can use the xenograft, or we can use the autogenous bone, which is the gold standard bone, and also we can use the alloplast tricalcium phosphate. However, I want to mention that the best graft to use when we do the horizontal ridge augmentation is the autogenous bone mixed with either the FDBA or the xenograft. Alloplast is not favorable unless if we mix that graft with a growth factor like BMP or PRP or any other growth factor that help in the bone regeneration. Because the alloplast it gives we call it dead bone. There is a very low percentage of the live bone. So when we place the implant, this bone can resorb very fastly under the load, and also if we get pre-implantitis, this bone can be resorbed very easily. According to the membrane, we can use either collagen membrane or EPTFE, which is non-resorbable membrane, or polylactic acid membrane, which is resorbable, synthetic resorbable membrane, or we can use the titanium mesh. So على حسب الستادي اللي شايفينه هون the triplet, the result showed that 87.9% of the implant placed in grafted area were successful. So they placed 364 implants and they got 87.9% success rate. However, from the 364 implants, they have three categories. So one group they placed the implant with the bone graft at the same time, and the success rate was 83.6%. The other group they did bone graft first, and then they come back and they place the implant in the second surgery, and the success rate for this group was 90.4%. With the third group, they placed the implant in non-grafted area, and they showed the highest success rate, 96%. Of course, when we place the implant in native bone, we get higher success rate than if we place the implant into grafted area. هلا كثير منا بيسأل which particle size it's better to use. يعني حسب مثلا إذا بنستخدم xenograft ولا FDBA graft. In the market we have small particle and we have large particle. طبعا نحن إذا بنعمل ridge augmentation horizontal or vertical with a particle, it's better to use a large particle sizes because it resorb slower than the small particle. وبالتالي it acts as space maintainers and gives sufficient time for the bone formation. However, حسب Sharpov study, he used FDBA small particle size, which ranges between 100 to 300 micrometer, and also compare with a large particle size, FDBA, ranging between 1000 to 2000 micrometer, which is like 1 millimeter to 2 millimeter particle size. So the result showed of this study suggests that smaller particle of FDBA plus autogenous bone enhance osteogenesis with more new bone formation when compared to the large particle of the FDBA mixed with the autogenous bone. However, in addition, the small particle of FDBA plus the autogenous bone tend to display more resorption than the large particle FDBA plus autogenous bone. فمثل ما شايفين small particles بتعطينا more osteogenesis. Why? Because it has more surface area and we have more interparticular spaces that allow the blood vessels to penetrate the bone graft. إذا عندنا مثلا large particle حيكون عندنا أقل interparticular spaces وبالتالي ما بتعمل osteogenesis as doesn't enhance osteogenesis as the small particles. But the small particle resorb faster than the larger particle, and that's why we prefer to use a larger particle in ridge augmentation to maintain the space for sufficient time until we got bone formation. So what is the theoretical biology behind the healing within the GBR sites? According to Dallin in 1988, regeneration of the osseous defect is predictably attainable via the application of the occlusive membrane. Furthermore, the membrane creates and maintains a secluded space, thus providing an environment to the osteoprogenitor cells which is permissive for recruitment and proliferation of the osteoprogenitor cells, differentiation along the osteoblastic lineage, and expression of the osteogenic activity. Another article by Nevens in 1992, space making is critical because it allows the cell in the isolated compartment to undergo amplifying cell division. The physical barrier is essential since it allows unimpeded healing from the bony compartment without competition from the proliferating connective tissue cells. However, movement of only 10 to 20 micrometers during the very early stages of the fracture healing is enough to divert the differentiation of the mesenchymal cells into the fibroblasts instead of osteoblasts. فمثل ما شايفين احنا دارين اللي هو اول من حكى عن الجي بي ار، مثل ما شايفين هون احنا لما نحط الميمبرين بنغطي البون ديفكت بالميمبرين، بنعزل الديفكت from connective tissue or epithelial cells، وبالتالي نسمح نحن للبلود clot to stabilize within the bone defect and also would allow the mesenchymal cell to differentiate into the osteoblast and subsequently bone formation. فدائما نحن لما نحط الممbrane we have to make sure the membrane is stable and also the bone graft should be stable. There is no any movement مثل ما شايفين حسب نيفن انه اي حركة بسيطة بالطعم العظمي او بالغشاء ممكن يؤدي الى فشل الطعم العظمي، بصير في عندنا تليف بالطعم العظمي، فبدل ما تتحول الخلايا الميزنكيمية للأوستيوبلاست تتحول للفايبروبلاست، وبالتالي بصير في عندنا fibrous encapsulation للبون graft. So which membrane is better to use, resorbable or non-resorbable membrane when we do the GBR? So حسب الارticle by Simeon, هون they compared the resorbable membrane which is polylactic and polyglycolic acid, it's sensitive to resorbable membrane, with EPTFE اللي هي non-resorbable membrane. They showed three groups. One group they didn't use any membrane, the other group they used a resorbable membrane, and the third group they used the non-resorbable membrane. And after 6 months, the EPTF membrane were found to be the most effective barrier material in that denser and a greater amount of the regenerated bone was found. The resorbable membrane produced some bone regeneration when compared to the control site, but to a lesser extent compared to the EPTFE sites. فضمن هالصدي أوجدوا إنه non-resorbable membrane is better to use than a resorbable membrane. Why? Because it's rigid, it's maintain the space for a longer period than resorbable membrane. Resorbable membrane can be resolved very fast before mineralization of the bone. هون البولylactic polyglycolic acid also can produce some inflammatory reaction, and it's not very common now in the market. Because of that, we mainly now use the collagen membrane. Now the main complication of the non-resorbable membrane is membrane exposure. So what is the best time to remove the membrane when we do the ridge augmentation? The average time for membrane removal is 8 weeks. However, the bone deposition occurs over 12 months period and peak between 3 to 6 months. Prolonged retention of the membrane may serve to stabilize this environment, allowing for increased bone deposition. And the most membrane exposure occurs within 2 weeks. The exposed membrane can be removed between 4 to 6 weeks. However, early membrane removal may result in decreased regenerative results according to the Murphy study in 1995. فنحن الممبرين لما نستخدمه طبعا الأفضل إنه نخليه as long as we can. لما يكون مثلا الممبرين مغطى بالتشيو ما في أي مشاكل، نفضل نخلي الممبرين لحتى نعمل الري انتري اللي after 4 or 6 months healing time. لكن ممكن نحن نشيل ممبرين بعد شهرين، بعد 8 weeks. هلا غالبا اذا بده يحصل ممبرين اكسبوجر بيحصل ضمن 2 weeks من فتره الشفاء. لما يصير عندنا نحن membrane exposure, we can remove the membrane after 4 to 6 weeks but not before the 4 weeks. هلا حنشوف ليش. حسب دراسة لسيميون, the partially occlusive porosity of the membrane seemed to be able to delay bacterial penetration through the membrane for approximately 3 to 4 weeks. After this time, the prematurely exposed membrane should probably be removed to prevent the bacterial infection of the underlying regenerating tissues. فالممبرين ممكن نحن يعزل لي الجرافتد اريا لحوالي 4 أسابيع 3-4 أسابيع من البكتيريا. يعني ممكن يمنع دخول البكتيريا فترة 3 إلى 4 أسابيع. بعد هالفترة طبعا البكتيريا ممكن توصل للجرافت وممكن يصير في عندنا مشاكل. فمشان هيك نحن يفضل إنه نشيل ممبرين بعد فترة 3 إلى 4 أسابيع من الإكسبوجر. لكن نحن مثل ما شايفين بالصورة هي، طالما حواف الممبرين مغطاية بالتشيو، يعني طالما ما في عندي exposure للإيدج of the membrane, we can keep this membrane as long as we can. يعني طبعا it depends on the oral hygiene, if there's an infection or not. يعني نحن إذا بنحاول نخلي المريض يكون عنده good oral hygiene، نعمل مضامد بالكلورهكسيدين ومراقب المريض بشكل دوري، ممكن نخلي membrane up to 8 weeks حقيقة ولو get exposed طالما عندي the edge is covered by the tissue. However, when the edge of the membrane get exposed, this will allow the epithelial cell to go underneath the membrane and also allow the bacteria to go under the membrane. So at that time, membrane removal is recommended. طبعا السبب الثاني احنا يلي ما بنحبذ انه نشيل membrane بفترة قصيرة. مثل ما شايفين احنا البناء العظم بيمر بمراحل. طبعا عندنا أول شيء first stage which is inflammation, then we have the osteoclastic phase, then we have the osteoblastic phase which is the bone formation, and then we have the mineralization and remodeling. So let's talk now about the surgical recommendation within the GBR. What is the main protocol that we need to follow in order to get the good result? So according to the Boozer study, it's a very well-known study. Here they describe a specific protocol for the reaugmentation or the GBR. The first step is the flap design and manipulation, which is a very important step. So we have to use a lateral incision technique on the palatal aspect in the surgical site with intact soft tissue cover and a combined split and full thickness flap. The second step is debride the soft tissue remnant from the surgical site. The third step will be perforate the cortical bone plate to open the cancellous bone and to achieve the bleeding bone surface. فإذا الخطوة الأولى هو حيكون الفلاب ديزاين. This is very important. الخطوة الثانية حيكون هو لازم ننظف تمام سطح العظم، والخطوة الثالثة هي إنه نعمل perforation لسطح العظم لحتى نزود من التروة الدموية لمنطقة الطعم. The fourth step is use an appropriate bone filling material for the blood clot stabilization, and then place a trimmed membrane to create space without extending into the sulcus of the adjacent teeth. This is a very important point. نحن لما نحط الغشاء لازم ما نخلي الغشاء يلامس ال adjacent teeth. Why? Because when we allow the membrane to get contact with the tooth surface, we will cover the sulcus, we will cover the whole crystal bone with the membrane. So we exclude the blood supply that's coming from the two sulcus from the periodontal space and from the crystal bone to the flap, and subsequently we will end up with flap dehiscence or opening and exposure of the membrane. هلا حنشوف في حالة عارضة صارت معنا هالكومبليكيشن هي بسبب انه الغشاء كان ممتد حتى الأسنان المجاورة. The other tricky part with membrane is closely adapt the membrane to surrounding the bone, extending 2 to 3 mm beyond the graft material to achieve a seal at the defect margin and to prevent the ingrowth of the gingival soft tissue cells. كمان من الناحية الثانية نحن الممبرين لازم يكون مغطي منطقة الطعم العظمي حوالي 2 ل 3 ملم حتى يعزل الطعم العظمي تماما عن الخلايا النسج الرخوي. So the membrane should cover the bone graft 2 to 3 mm beyond the bone graft 2 to 3 mm, and at the same time the membrane should not touch or cover the adjacent teeth sulcus. Then fix and stabilize the membrane with a fixation screws or periosteal mattress suturing. Use horizontal mattress and interrupted suture to achieve the tension-free primary closure. This is also very important. We have to get primary flap closure without any tension. And then leave the membrane in place for 2 to 6 months. Depends on the defect size, membrane exposure, and the graft material. Of course, if we have larger defect or larger augmentation, we have to keep the membrane longer time. So this is the first case I would like to present. A patient came with a deep pocket around the lower incisor, and we can see the tooth on the X-ray. We can see the tooth had a root canal in the crown, and there is bone loss on the mesial aspect. So we decided to do exploratory flap to see what's going on, and during the surgery we found there's a crack on the tooth, so we had to extract the tooth. So after I extract the tooth and clean the defect, I found there is a significant bone loss, so we end up with only 2 wall defect. Of course, patient wants implants, so we had to regenerate the area. So we clean the defect from all the soft tissue, from all the inflammatory granulation tissue, and then we applied the FDBA bone graft. We cover the bone graft with non-resorptive membrane titanium reinforced membrane. Here, as we can see, the membrane extended to adjacent teeth. So I will show you now the post-operative picture. So we extend the flap and we get the primary closure. Now here, after 4 weeks, we can see now the membrane get exposed at the crystal area and at the proximal area of the adjacent teeth, because we extend the membrane too much and we exclude the blood supply to reach to the flap. So that's why we end up with the exposure. However, I keep the patient on good oral hygiene with a chlorhexidine, irrigation, and as we can see, after 4 weeks, I removed the membrane. Here, I didn't have to do any big flap to remove the membrane because I didn't use any metal screw or metal tacks to hold the membrane. It was just a horizontal periosteal suturing to hold the membrane. So it came out easily. And here we can see in the next picture, 10 weeks healing. We can see the tissue granulate in and cover the crystal area. At 4 months, we can see complete healing of the soft tissue and the bone graft area. So after 4 months, we came back, and on re-entry, we found that we have a very good bone, solid bone. So we did the osteotomy for the implant. The implant was placed with a good torque, as we can see on this picture, and then the implant was covered. And here we did the stage 2, and we can see now the final picture and the x-ray were taken 2 years after the restoration of the implant, and we can see we have a very good tissue architecture, healthy gingival tissue, and good bone level. There was no any defect or any bone loss around the implant. This is another case. Patient came with severe bone loss, severe chronic periodontitis, and also with a significant bone loss periapically. So we end up with extract of the upper anterior teeth, and with rising the full thickness flap, we can appreciate the defect and the bone loss. So we can see the decortication around the defect to increase the blood supply to the graft area. And the last picture showing the membrane. This membrane called sonic weld membrane, it's a polymer membrane, resolvable. Of course, it's a special system. I just would like to share with you this system. So this system called sonic weld, and it has a specific device. As we can see on the right side, they have special drill, so we do the pilot holes, and then there is resolvable polymer pins. So we use the core component of the system, which is an ultrasound generator, which liquefies the sonic pin by means of micro vibration. So it gives micro vibrations and it's liquefy the pins. So the pins will be inserted into the pilot hole with a slight pressure and with the micro vibration, so it's gonna fuse with the internal side of the bone. So membrane comes rigid, so we put it in warm bath, warm water, so in order to be able to shape the membrane and manipulate the membrane. And then we can of course trim the membrane according to the size of the defect, and then we apply the membrane on the top of the pins, and then we use a device to liquefy the membrane to the pins, so the membrane will be fused with the pins and we end up with like a pouch. صيانة مثل جيب باستخدام هالتكنيك هذا، وبعدين بنعبي هالجيب بالبون جرافت. It's very nice technique, provides stable membrane, a stable bone graft, and it's good space maintainer for ridge augmentation. So this is the same case that we talked about. So as we can see, we applied the bone graft, and we like to cover this type of the membrane with the collagen membrane, because sometimes this membrane has a sharp edge. So in order to have better soft tissue healing, we cover this membrane with other resolvable membrane just to have better tissue healing. The last picture showing the tissue healing after 1 week. And this is after 6 months. We can see on the x-ray the amount of the bone gain. So we have a good bone regeneration. So we place the implant, and here we can see at stage 2 the amount of the bone that formed. And so we did apical position flap, try to increase the amount of the keratinized tissue around the healing abutment. This is also another case. Here we can see there is a thin alveolar ridge on the lower anterior area, and here we used densabair, the osteodensification technique. So we did ridge augmentation after we placed the implant. So first of all, we made a small trough using piezo surgery, and we can see there is no vertical bony cut, it's just a crystal cut. And with the densabair, we can expand the ridge, and then we place the implant. And of course, because we have a thin layer of the bone, so we need to do like a ridge augmentation or only grafting. So we applied the bone grafts, and we covered the bone grafts completely with the collagen membrane. We stabilize the membrane with horizontal suture, and we get the primary closure, and the final x-ray and the final picture showing the implant with a good soft tissue and bone healing. This is the last picture after 1 year of the implant placement. And this also another case. Here the patient had a root fracture, as we can see on the picture. So we now extract the tooth, and here we can see the amount of the bone loss and the defect the completely loss of the buccal plate. So we did the decortication with a small round burr, and here we can see we trimmed the membrane and we keep the membrane away from the adjacent teeth, and we stabilized the membrane with a tacks, and then we applied the bone graft. Here I used the BioOS, the xenograft, and we completely cover the bone graft and suture back the flap after the extraction. And this is 6 months healing. We can see there is a good soft tissue healing and good bone regeneration. And this is at the time of the implant placement. And this is at stage 2. We can see here the amount of the soft tissue and the bone tissue on the buccal aspect of the implant. So we have a good shape, and also we can see we have good stability of the implant according to ISQ reading. And this is the final impression. So see here on the labial aspect of the implant how the tissue is thick, which is what we like to see. And this is the final restoration. So now I'm going to talk about soft tissue ridge augmentation briefly. And there's different technique actually regarding the soft tissue ridge augmentation. So we can either use only free soft tissue graft, or we can use subepithelial connective tissue graft. So for the first picture here, as we can see, we can do full thickness flap, and we can use connective tissue graft, and we can slide the connective graft, under the flap and suture back the flap to increase the thickness of the soft tissue. The lower picture it took from a Siebert article. It's an old article in 1983, and we can see from the picture there's a ridge deficiency, and they used free juvenile grafts. So they deepitalized the crystal part of the tissue, and then they applied the free soft tissue graft on the top of the ridge and suture the graft, and we can see the healing after that, and the patient ended up with fixed bridge. So this kind of technique can help to minimize any bad appearance, of the pink porcelain, or especially if the patient has a high smile. So it's not always good to use a pink porcelain to overcome the ridge deficiency. Sometimes we have to do soft tissue grafts. So according to Arthur's study, modification of the connective tissue graft procedure for the treatment of type 2 and type 3 ridge deformities. So we can use the soft tissue to treat type 2 and type 3 ridge deformities. So we don't need the bone graft or membrane in every cases, and also we don't have to deal with the bone failure or exposure of the membrane. So sometimes we just need to improve the aesthetic appearance for the tissue. So this is last case. Patient came with a temporary bridge. We can see there is a ridge deficiency. Here at class 3, there's horizontal ridge deficiency, and also there's vertical ridge deficiency with the recession of the soft tissue. So we removed the temporary bridge, and we took the soft tissue graft from the tuberosity. It's a very nice area to harvest the soft tissue, because we have thick tissue and it's less painful to the patient, and there's less also bleeding tendency at the tuberosity area than the palate. So we use the connective tissue graft. We applied on the side, and then we cover the graft with the flap. We advance the flap coronally, and here we can see the difference between the two pictures. So we got horizontal and vertical soft tissue augmentation, and we cover the recession area. Now the patients can have the final bridge without using the pink porcelain. So as a conclusion, to achieve the successful result in ridge augmentation, first of all, the flap design. We need to have primary closure with tension-free suturing, And the second important part is doing the decortication of the recipient side. Stability of the graft and membrane is very important also, because any mobility or movement of the membrane or the graft during the healing time can end up with a fibrous encapsulation and failure of the grafting. Also, rigidity and long-lasting membrane is very important. We need to have a rigid membrane, long-lasting membrane, so it can maintain the space for the blood clot formation and subsequently for the bone formation. No mechanical pressure on the grafted site. Of course, when we do temporary restoration on for the patient, we don't want to have any pressure on the grafted site. Always try to relieve the partial or the flipper that you have, and try to avoid any pressure on the grafted site because it may cause flap dehiscence or flap or membrane exposure and subsequently failure of the grafting. Patient coverage with antibiotics and anti-inflammatory medication. Always, when we do any kind of the grafting, give your patient antibiotic and anti-inflammatory medication for 1 week. And also, we need to follow up with our patients frequently. We recommend every 1 week, 2 weeks, and then 4 weeks, and then every 2 months and 3 months, depends on how tissue heals. And of course, the membrane should kept at least for 8 weeks, unless if it's get exposed or get infected, then we need to remove the membrane before the 8 weeks period. At the end, I would like to thank you for your attention. شكرا جزيلا لإصغائكم. أتمنى أن تكون المحاضرة قد عادت بالفائدة على الجميع. شكرا مرة أخرى للدكتور مازن دوماني، وإن شاء الله نلتقي في برامج ومحاضرات لاحقة. نتمنى التوفيق للجميع. دمتم بخير، والسلام عليكم ورحمة الله وبركاته.